All right, good evening. We are at the osteotomy online course, and this is the diaphyseal and distal tibia meet the experts session. And I'm the moderator, Brett Christ, and tonight we have Mitch Bernstein, Sean Nork, and Tim Weber, and then we have some of the other faculty from other modules as well, like Jim Stannard, and I believe Mark Lee's joining us. These are our disclosures, which for this part isn't really that relevant, but they're there just for your viewing pleasure. We are recording this session, and all of the content is the property of AONA and AO Trauma North America. If you don't wish to be included in the recording, we already have your camera off and your microphone muted, but if you have any issues with the recording, please make sure those stay muted and off. For Zoom meetings, everybody's done these, and this is it feels like the 50th installment of the osteotomy course. And so just make sure you're using the Q&A function to ask questions. And that way we can track your questions so we can modify the content for the next course to try to address things that maybe we didn't get to this time. So please use that function rather than the chat function. And there are too many participants to do the raise hand function as well. So please just filter your questions through the Q&A function. So the learning objectives for this module were to list the indications for tibial deformity correction and non-union management, utilize deformity correction techniques to restore extra-articular alignment, utilize the operative techniques for intra-articular distal tibial osteotomies, and then recognize strategies for leg lengthening or more specifically bone transport. So these are our faculty, and folks highlighted in red are those that were part of this module. And so Mitch started off on Saturday with the discussion on dealing with bone loss, and particularly going over bone transport. The learning outcomes for his talk were to appreciate the reconstruction ladder of bone defects and describe the distraction osteogenesis, or the Elizaroff method, and then execute the plan for bone transport. So this is one of his slides about factors to consider when you're considering transport or just dealing with bone voids. You know, is there an infection? Is it periarticular? Where is it? And specifically the type of host that the person is, looking at the total defect size plus the leg length discrepancy. And so I thought this was really interesting that he brought up the AO trauma principles and then put up Elizaroff's principles, and they really do kind of parallel each other. And so it's definitely familiar to all of us. So the different ways that you can do transport, there's a variety of them: lengthening over a nail, lengthening and then nailing, cable pulley system plus IM nailing, all internal bone transport assisted systems, and then plate assisted bone transport. This was a case that he showed, and looking at the total time for days in the frame, and then the ability to shorten that amount of time by adding the magnetic nail that cuts down on the total time in the frame. This is a cable transport over a nail, and if you go to YouTube and look up this, it's Mitch's YouTube video that I think has over 1 million hits. I think I've looked at it well over 20 times, so it's a great video. And just it really helps kind of bring home how to do it over a nail. And then he also mentioned Steve Quinnan's articles about cable transports as well. And there's lots of different articles out there that are from other countries, and just it's a good idea to really understand the technique before you jump in. And so these are just images of from his talk showing the all internal bone transport with the nailing system that's magnetically driven. And so that internal segment where the screw holes are at the bottom, which you can see down here, that moves up with the motor, and that's what transports the segment from distal to proximal. So the summary and future directions: Elizaroff method is still a powerful tool for limb reconstruction. You have to adhere to the principles despite changing technologies. The principles stay the same. You can combine strategies to make it easier on the patient, and a lot of times it's easier on you as well. More integrated techniques continue to be developed, and it just, I think overall is more beneficial for the patient, particularly the all internal bone transport techniques. It's very exciting. So then Sean went over very articulate and mind-blowing talk on mathematically directed single plane osteotomy. If you understand math, you will love this. And it's just a really intricate way of doing multiple plane deformity. And it's based on these articles by the San Jordan brothers and trying to correct deformity. So this was a case example that he had of this primarily varus deformity, but as you figure out with the model, it's more than just that. And that's why evaluation is important. And so Raul Vadia has been great about sharing the Bonesetter app that you can go to learndetroitbonesetter.com, and you can practice the evaluation and practicing osteotomy techniques for Sean's cases, and they're labeled SN case 1, and then you'd have to put in SN case 2, and then SN case 3. And so if you can try to do that, I know it's Saturday is just a couple days away, but if you could try to work on that over the next couple of days or within the next week, we'd like to see what you guys are able to come up with. And so this was rule number 1 from his talk: angular deformities in multiple planes without translation can be calculated as a single angular deformity. So that's important that it does not have translation. Rule 2, by determining the sum of the deformities in 2 perpendicular planes, the no deformity, or where the deformity disappears, and then the maximum deformity views are calculated. And so this is that case that he created a 3D model. And you can see in both the AP and lateral views. And then the mathematically directed osteotomy is nothing more than a single oblique osteotomy with a bit of math and thought to correct these problems with oblique osteotomies. So then it's really critical to understand if you do an ascending or descending cut, because it totally does matter. Like he said, one direction corrects the rotation and the other direction doubles it. So nobody wants to do that. So these are some of the angles that are created and where the entry angle for the osteotomy is relative to the transverse axis, and I'll show that he had on the model, and then relative to the frontal plane. And so this is a program that I believe it's a resident and fellow there at Harborview have been developing with him to help kind of calculate these angles without having to make your brain hurt with drawing diagrams, etc. So I've planned these before, and it's taken, I did a distal femur and a proximal tibia, and it took me 6 hours. So maybe I'm just not that great at math, but it takes a lot of thought and careful planning. So this is the example of what happens when you do it as far as if you do ascending or descending, and what happens to the rotation if you do it correctly or incorrectly using a simple coffee mug and a paper plate. So this is for that particular case that he made the model for. So these are all the angles that are shown. And so it's a 56-degree angle osteotomy from proximal to distal, oriented 7.5 degrees lateral to the purely sagittal plane. And you can see that here, these are the pins that set up for basically the oblique osteotomy in relation to the perpendicular to the no deformity. And then this is what it looked like post-operatively. And you can see that there's a ton of compression with the lag screws and then protection with the modified plate. So his take homes were that this may be used infrequently, but it's super useful and elegant for those multiple plane osteotomies that don't have translation. Do the math. It's not that, it is hard, but it's not that hard, especially if you reference the article and understand. And you can also look at all of our lectures on YouTube, which I'll show you at the end how to get to that. So rotation occurs with every oblique osteotomy, so don't double it by going the wrong direction. ascending or descending. Steepness of the obliquity determines the amount of rotational correction, and direction of the obliquity determines the direction of the rotational correction. So angle phi is critical for avoiding introduction of a deformity on the no deformity view. So for that section, the summary was, list the indications for tibial deformity correction and non-union management, and then recognize the strategies for leg lengthening and bone transport. And then we went to extra-articular deformity. Tim Weber went over that topic. And so the learning objectives were to appreciate the importance of the clinical exam and the anatomy, a strategy to managing the fibula, and then review some case examples. So these are the osteotomies that he mentioned: rotational, medial, whether it's opening or closing versus dome; lateral, opening or closing versus dome. Consider previous incisions and soft tissues and indwelling hardware as well. And then what do you do with the fibula? We talked about if it's more than a 10-degree amount of correction in any plane, then you would want to consider doing the fibula. And then what do you do with it after you do the osteotomy? So here's a case example of complaining of right knee pain after previously nailed tibia fracture with extremity alignment series and the AP and lateral views of the tibia. You can see that there's a 20-degree difference between the femur and the tibia, where the femur is internally rotated 3 degrees and the tibia is externally rotated 17 degrees relative to each other. So then he talked about an interesting technique using 3 wires instead of 2, because if you're using the triangles with the degrees on it, that it is kind of difficult to kind of eyeball it from your point of reference. So if you set up 2 wires distally, one with the amount of correction that you want, so say it's 30 degrees, and then the other is positioned at the starting point. So it's just another plane of reference that parallels the triangle sides. And then it also can help with potentially just another frame of reference instead of necessarily using like a goniometer. And so these are the clinical images, fluoroscopic images showing that he did a fibular osteotomy and used that rotational correction and then put a new nail in. And this is her both a thigh foot progression angle and then ambulating in clinic. This is another example of congenital valgus, and so that's a lot of valgus at the ankle. And then somebody ended up doing osteotomies of the fibula and tibia and created some angular deformity in the sagittal plane, and then went back and revised that, and with a medial plate, you can see the correction. And this was an interesting case of somebody who had surgery for arthritis essentially and became unstable after an anterior chilectomy. And so this is with him putting manual stress on the lateral image in clinic. And you can see that the anterior distal tibial angle is significant at 74 when it should be around 80. So you can also look at that case on Bonesetter, at Learn Detroit Bonesetter, and you just have to put in your name and then you put in the TW case 1, and that will allow you to start using the software. And you can also sign up for just a regular version as well at DetroitBonesetter.com. And this is what it looked like at 2 years follow-up after the osteotomy correction with revision with a posterior plate. And he increased the anterior distal tibial angle to prevent him from subluxing anteriorly. And so his take-home lessons were carefully evaluate subtalar motion. Most angular corrections will be done from the medial side, just because of a lot of the deformities that we see, but also maybe because of access. Fibular osteotomy is done. We talked about if there's more than 10 degrees of correction in any plane, and then allow it to seek its position. And most of the time, depending on where you have to do the osteotomy, it's left alone. Restoring normal anatomy can produce satisfying results. So then we went on to intra-articular osteotomies, and we talked about the most common presentations, which are typically delayed fracture presentations or intra-articular malunions. And then we talked about gastroc recession to help with that, to avoid kind of what that guy with arthritis had, where he really wanted to squirt the talus out the front. So if you lengthen the posterior complex, you can help avoid overstress of the anterior plafond. So these are the angles that I briefly mentioned, the anterior distal tibial angle. And then on the coronal plane, it's the lateral distal tibial angle. With intra-articular deformity, you want to get a CT scan, and then you may want to consider an MRI if you have concerns about the articular cartilage thickness, trying to determine what procedure to do, or if there's any soft tissue concerns. So this is a case of Sean's that presented 14 weeks out from injury, and these are the CT scans that they had. When he saw them, you can see that there's some callus formation on kind of right here, and then starting to form here, and just kind of the challenges of dealing with this fracture. They're hard enough to deal with acutely, but basically these are the things that you need to kind of think about. So how do you see the intra-articular involvement, the joint subluxated with cartilage impingement? How do you regain length? What's your fixation strategy? So using Distractor, was able to get length, approached it posterior medial and posterolateral, and then went on to do compression of the articular surface, and then supporting that with plates above it, and then fixing the fibula as well, and using the prior fracture planes to get it back down. So the take-homes for intra-articular osteotomies or CT scans are critical. You want to understand how you can regain length if things are short. For delayed fractures, for the most part, you're going to use the previous fracture planes and then use standard fixation principles. So for those two talks or lectures, it was utilize the deformity correction techniques to restore extra-articular alignment, and then utilize the operative techniques for intra-articular osteotomies. And so it looks like there's one question from the audience, and you can keep using the Q&A function, and then we'll kind of move on to cases if there aren't that many questions. So when using the 3-ring fixator construct, distracting the segment from proximal to distal, how do you run the spatial frame program to account for the proximal ring and distal ring segments to get the program to account for motion at the same time as both rings to avoid inducing deformity? So Mitch, do you want to take a stab at that, and then I'll also chime in?
So when using a 3-ring fixator construct, so you're
so how do you do the program to avoid problems?
We're talking about a transport.
Yes.
Okay, so we're talking about bifocal transport with stacked hexapod circular fixating. He's talking about Smith and Nephew's Taylor spatial frame, specifically to account for the proximal ring and distal ring segments to get the program to account for motion at the same time at both rings. If you seem to, do you have a better stab at it, Brett? I don't really do anything. Well, to answer, when I do a bifocal transport like this, I really don't do anything specific. I usually, you have to have a 1-to-1 ratio of how much you're moving. So the proximal has to collapse the same amount as the distal two have to distract. And he's talking about a distal to proximal transport.
Yeah. So what I would see this as is that if you're doing a pure transport and not having to do any angular rotational correction, you're basically going to use the Lizaroff clickers. And so it's really just threaded rods, and you don't even need the program. You don't need the hexapod struts. You can just use clickers, and it's just basically you do the same. Basically, if you're moving the distal segment proximal, you're going to use both clickers in the same direction, doing your correction 4 times a day. You know, I always tell them to go whichever shoulder it is that it needs to go to, so they don't get screwed up and go the wrong way. But usually if you're just doing a transport, you're gonna, as long as you don't have to do any angular rotational correction, I would just use the clickers and just do it simpler, just because it's easier for the patient too.
Yeah. I mean, so you could do that. And then just another subtlety is if you cut the fibula or excise some of the fibula, then each segment can move independently, which is a different concept. You can collapse the dead space independent of the transport or distraction. That's more of a shortening distraction technique. But you basically, if the fibula is intact and you're doing a bone transport, you can either do what Brett mentioned, or you're sort of constrained to collapse and distract at the same rate. I don't do any, I sort of think I know what he's talking about a little bit, but I don't do anything special to the computer program.
And if I'm doing it where it's, if I do have to do the hexapod for 2 of the rings, and the other is just, you know, if you have 4 rings or something like that, where it's more complex and you just do lengthening through a different part of it, then I just tell them to do the clickers for the regular linear part, and then you can do the frame for the other part. You just have to make sure you're going in the correct directions.
Yeah, and there is some wiggle room, you know, as things translate or angulate, there's some wiggle room to move it back. So I don't do anything. I do bifocal transport with hexapods. I don't do anything specific, and I do use this software.
It's good that you do. Thanks, Mitch.
Thank you.
All right. Seeing no more questions, we will move on to the cases. All right, so case 1, this is a 42-year-old female with hypophosphatemic rickets. And you can see this is from her scout view from her CT scan that she came with. And she has seen endocrinology. She was started on Crysvita, which one of the things that I commonly see with patients like this, or anybody who has osteogenesis imperfecta or any metabolic bone disease, once they hit the age of 17, it's like nobody wants to see them anymore, or 18, I should say. And so oftentimes I think part of the thing that you need to do is help them get lined up with an endocrinologist, or if you have a bone health specialist. But she's complaining of bilateral tibia pain, bilateral femur pain, and then left hip pain. So by seeing, I sent her to endocrinology, and her phosphorus and PTH have now normalized. And this is what on her exam, her thigh foot progression angle on the right side was 50, and her left was 35, and this is her walking. And the block is because she turns around, so I don't want to get any crap about the block. So that's her trying to walk with crutches. So these are her plain films. You can see she has a stress response or fracture in her tibia and kind of mid diaphysis, essentially, on both sides. You can see that she has knee arthritis on both sides. And although you have a good kind of AP-ish mortise view of the ankle, you can see her patella is kind of not completely centered, and she's embarrassed there. This is her angular deformity in her both tibias in the coronal plane, so 13.6 degrees of varus on the right and 16 on the left. And that's basically the CORA, or intersection. And then the sagittal plane, you can see that she's got some rotation stuff going on, because you've got an AP of the ankle and a kind of a oblique lateral view of the knee on both sides. So to me, I'm not really going to be able to necessarily help with plain film. So that's where a CT scan is helpful. So her left tibial rotational profile is 23.4 degrees of external torsion, and her right side is 17.1. And then this is an awesome book. There's a bazillion case examples. This is Rennie Marti's Osteotomies for Post-Traumatic Deformities. And there's a lot of what's considered normal for a lot of different things that we've talked about in the course. And you also have Dror Paley's book. Other references have been mentioned, but this is what the reference for this diagram is from. So 23 plus or minus 5 is considered normal. Internal tibial torsion less than 10 degrees, external greater than 35, and for both sides. And so this is the problem list that I see. We're not going to spend a lot of time on her femurs, but she's got bilateral femoral stress fractures, left femoral neck stress fracture, bilateral tibia stress fractures. She's got a Rickets. She's got bilateral knee arthritis. I forgot to put she also has ankle arthritis, genuvarum, and rotational problems. So I can go back and show the x-rays for tibias. What are you guys thinking? Sean, Mitch, Tim, any other faculty?
So I think one of the critical things when there's a stress fracture with associated deformity, it is foolhardy to think that you can get a stress fracture to heal without correcting the mechanical axis of the extremity. So I know we're focused on the tibia, and I know you were focused on the entire extremity, but assuming that one makes the femur anatomically correct in terms of its alignment, there's still a varus deformity of the tibia as well. And so I think once the deformity of the tibia is corrected, then you can get a stress fracture to heal. But that's just a basic principle. So assuming you can get the mechanical axis correct of the femur, then it's just a question of how to correct the varus deformity of the tibia. And I'm sorry, once again, Brett, what were the rotation from normal?
So she had 17 of external torsion on the right and 23.4 on the left.
Meaning that's sort of within, like I wouldn't say that's too pathologic. Is that what we're saying?
No, I thought he meant he was just asking what it was.
Yeah, I was. We'd seen those one X-rays that looked rather bizarre in terms of the rotational profile at the knee and the ankle. But based upon the CT scan, to me, she starts to become, with regards to her tibia, a relatively pure coronal plane deformity. And so I'm not, those rotational profiles look reasonable to me at the tibia. So I'd be looking at this as a pure correction of a proximal tibial varus deformity. Okay. And so my vote, everyone else can chime in, but I would probably vote for a biplanar medial proximal tibial opening wedge osteotomy, since she's not tall.
Okay, so just basically at the typical spot, or would you try to go where her CORA is?
I think I would probably, I'd obviously draw it out, but I would anticipate probably being able to do this at a typical spot with a oblique osteotomy from medial towards the ascending towards the fibular head, with the biplanar component to just undercut the tibial tubercle. So it doesn't affect her infrapatellar tendon too much.
Okay, so biplanar osteotomy. You would do a biplanar, so you'd cut parallel to her tubercle, right? Is that what you're saying?
Yeah, so the main osteotomy to open up her medially, her coronal plane, and then just the obliquity beneath the tubercle.
Okay.
Kind of the Lobenhofer approach, yeah.
Yeah, yep. Mitch or Tim?
I would try to see if I can do it with an IM nail, even though, I don't know if it's truly pathologic bone at her age. She's made it thus far without breaking things. I don't know if you need to put IM nail to, quote, protect the whole bone like you would do with other metabolic bone diseases, but I would try to do this with an IM nail. I'm a little concerned about the acuity, the magnitude of the deformity correction with an HTO. I'd have to calculate it also. Once it gets over 13, 16, 17 degrees, the wedge is quite big, and then the hinge can break. I'd also like to calculate the apex using a MPTA in the proximal segment instead of an anatomic axis line, just so that you can do the same in the femur, and then that'll help you get your mechanical axis at the end of everything neutral or medial, or you can mathematically determine that, or at least put it into Raul's Bonesetter app or any other virtual software to play with the cut.
Tim?
Yeah, I guess I would probably try to lean towards using a nail as well, in the sense that treating that stress fracture, it allow you to treat the stress fracture below it there too. So I guess maybe my osteotomy would be closer to the CORA than higher up. But I think Sean's option is absolutely a good option as well.
What about a clamshell, Sean, in a tibia? Have you ever done that?
No, I know plenty of folks have followed the principles and had very good results with it. And in fact, one of my partners, Dave Barre, just did one last month or 2 months ago. So I think it is an attractive option. I just get really nervous at the tibia. It's because of potential compartment issues.
Jim Stanner, what do you think of, what is your, I know we don't have I didn't give the MPTA because I didn't want to get distracted with the femurs, but what do you think about your maximal correction for proximal tibial osteotomy? Is there a number, you guys did the periarticular knee session, is there a number that gets you pretty nervous as far as the amount of correction?
When you start getting up to 12, 14, 16, 18 millimeters of opening, I definitely want to see what those angles are, because it starts to get, and I frequently find when it's a huge amount, you do need femur as well. And of course, this patient has femoral problems, but I think this patient you probably could get away with, I would guess, the tibia and be under the amount that makes me really nervous. But I definitely would want to bone graft if it's a pretty wide opening, which I bet it will be.
Okay.
Yeah, I would graft that for sure, I think, because it's going to be a huge opening.
Mark, any other thoughts? Mark Lee's on.
Yeah, I actually I like the nail concept for that stress fracture for sure. And I'd actually like clamshell for this. I think you're going to be dealing with a pretty short segment, but with modern nail technology, I think that's less of an issue. So yeah, for Rickets patients, especially with or without stress fractures, I certainly am trying to use an intramedullary implant. So I'm in that camp.
Okay. Well, I won't delay the suspense any longer. So this is what she looked like after I did a clamshell on both femurs. This is immediate post-op. But so we got at least addressed some of the things that were going on with her femurs, and she's got recon screws on both sides, but the left one was to address the stress fracture. And they were pretty long clamshells, as you can see. But we still needed to kind of address the rest of the things. And so I thought of a clamshell for a couple of different reasons that were brought up. So number one, I didn't think plating proximal tibial osteotomy would address her stress fracture. So I wanted to use a nail concept. And then also her bone did make me nervous as far as plate fixation. And so this is the kind of the subsequent article to the femoral clamshell osteotomy paper. from George Russell and folks out at Harborview and Michael Archdeacon. And just I wanted to show that figure because it is different as far as where you create the clamshell for the tibia, because there is a soft tissue concern. So it's more anterolateral to posteromedial. And so you make your, just like the other one, you make your kind of section basically perpendicular to the anatomical axis. And then I also was planning on fibular osteotomies and try to just match the rotation. And so looked at, because she's smaller statured, I want to make sure that I could actually get a nail down her canal, which I thought I could, but just it's always a good idea to measure. And so I'm just going to show the left side as the example. So this is the proximal fibular osteotomy, and I specifically wanted to go close to where the osteotomy was and identify the peroneal nerve and make sure it was protected. And then just pin the syndesmosis just to avoid any potential catastrophes. And then did the starting wire for the nail, and then put in the wires from the not through the incision, but through percutaneously through the anteromedial or the medial side. And you can see the fibular osteotomy was an oblique osteotomy right here. And then that's showing the drill sites from the anterolateral exposure and protecting with the Crago retractors. And then putting on the distractor to help with correction, and just because it doesn't get tired. And then kind of where the pins were placed, and then I used those, got them basically parallel for at the end. That was before the correction, and then did the connecting the drill holes and cracked the medial cortex. These are special osteotomy osteotomes, which are awesome. And I appreciate Mitch for exposing me to them. But this is what it looked like with the distractor in place and the lamina spreader at the osteotomy. And then mechanical access check. And basically the pins were starting to bend, and I was getting a little bit concerned about the amount of distraction I was doing, like it wouldn't last. But had to create a nail path with the T-handled reamers because of the stress fracture. The guide rod wouldn't go through. This is the guide rod centered and then reamed, and you can see the reamer going through the osteotomy segment. You're just passing it through it and then reaming above and below. And then proximal locking bolts. And it was a short segment. Checked the alignment again. And then couldn't really, the same thing kind of happened with the femur. Her soft tissues really restricted complete correction of the mechanical access. But that was about as much as I could get her soft tissues to correct. And that's what it looked like on the anatomical axis. So I just put the guide rod along the axis of the tibia. Just to
Can I ask you a question back one slide, Brett?
Sure.
For like that's a huge correction, not in a bad way. You can see the fibular osteotomy. Do you have any words of wisdom to, like, how do you know if it's too much vis-a-vis post-operative compartment syndrome or common peroneal nerve injury?
Yeah, so great question. I think although it was a fairly small incision, I made sure that what I could see of the nerve was freed. So I knew I was gonna put it on, I wouldn't necessarily put it on stretch because it's not a valgus deformity. So I wasn't as concerned about doing a larger peroneal nerve release, but anything over, like, not for this, but just like rotational, I mean, I think anything over 30 degrees really makes me nervous. I think anything in the tibia over about acute correction of, more than about 15 degrees makes me really nervous. And so like this one made me nervous for sure. Anybody else have any kind of hard guidelines as far as what they use?
No, that's about the same ballpark. I have been amazed sometimes though, because sometimes I'll wait to cut the fibula and see what I can accomplish, just as you did with a distractor for a correction. And sometimes I'm surprised at what the fibula can take at the proximal and distal syndesmoses. But yeah, it seems like, you know, anything over about a 15 degree rotational correction, you probably need to do a fibular osteotomy. And then coronal plane, I think less likely going from varus to valgus, but certainly on this huge of a correction, yeah.
Tim, any other thoughts? Sure.
Yeah, I just was curious as to, you know, when you sort of went back through the case afterwards, like the proximal osteotomy there doesn't seem to have opened up very much. Do you think you needed the clamshell, or do you think you could have, it doesn't look like that proximal osteotomy changed much. And could you have gotten your alignment with just a single cut?
Yeah, I may have. It did change more on the sagittal plane, but I was a little worried about basically getting the nail into the canal without losing some of the correction if I didn't have that flexibility more proximally.
Sure.
With that amount of correction. But I sure could have tried.
Well, I mean, you know, you're the one who was there. So, you know, what it looks like on film doesn't matter as much as, you know, what you were seeing in the operating room. And I mean, it's obviously lined up excellent. I mean, it looks great. I'm not criticizing. I'm just asking.
No, I know. Yeah. I think the, you know, a single plain osteotomy wouldn't have been, you know, that could have worked for sure.
I hate supporting Brett, but I agree. It looks like that on that plain film, Tim. But I'm always a little nervous about what I see that with the metaphyseal osteotomies, where you get a little bit of asymmetric opening, and I'm always a little concerned about the creating that rigid fixed gap, you know, with a single cut. I think you get a little bit more mobility having that segmental section. So I've seen that a few times, and yeah, I'd like to criticize it too, but I think I like the fact that you got a little mobility of that segment to actually let it heal.
One thing though, I mean, to Tim's points, I've done some pretty reasonable deformity corrections with coronal plane deformity corrections with an intramedullary nail as an effective opening wedge. So just a low energy corticotomy and allow it to open, keep the reamings in place. So close the periosteum prior to reaming. And this was something I got from Tom Higgins. He showed several cases and I'm like, no way that's going to just magically fill in. But they do. Once again, I don't want to get people in trouble and say you can do a total wackadoodle correction with a single cut, but one might be surprised.
Yeah, you know what? We're looking at R-non union rates a little higher than I like with these clamshells, and I'm just a little more nervous. So I'm gonna say I've seen that work by Tom, and I think you're right. I think if you use a perfect technique, you got a really good shot at that. I'm still working on perfection, so maybe I'm just not quite there yet, but I'm not quite as successful on that front.
I would just like to point out two breakthroughs for Mark. Number one, he supported me, and number two, he recognized that he can still get better. So I really think we made a breakthrough tonight.
Bam.
Yeah. So
and we got two different osteotomies. We got a clamshell and a wackadoodle.
That's the new one. Let's come up with what that looks like, the wackadoodle osteotomy. So this is what she looked like after the left side was done clinically on the OR table. and then went after the right side, and then that's what it looked like at the end 6 hours later. And so this is her 6 weeks post-tibial osteotomies, and I let her start weight bearing. Her femurs are starting to heal. And this is where she starts walking. That's her left side. She did have a peroneal nerve palsy on the left, so that gave me a little bit of heartburn, but she's wearing, she's not there, but obviously she's wearing a supportive brace. And then this is 9 months, and her peroneal nerve recovered around between kind of the 3 to 6 month mark. But this is her walking, and she actually doesn't use a cane. Our clinic's pretty far from the front door, so she brought her cane for that. But at that time, she was back to work, and she wasn't using a cane for at least walking around her house or kind of normal distances. So this is the last one at 13 months. So her femurs look like they're healed, and her stress fractures there. Maybe not completely in the back on the left side, but she wasn't having any pain. This is her left tibia, looks good. I think really happy with that. Right side still, like Mark was indicating, maybe the union rate isn't as good as we hoped it would be, but she's not having any pain. So she's going to come back 6 months from then. And she really wasn't having any pain. But you can see she really only has maybe kind of 2 out of the 4 cortices bridged on the distal part of the clamshell on the right side. And that's her mechanical alignment. So it's not perfect for sure. And these are her angles using the Bonesetter app. So definitely not normal, but definitely improved from where she was. And if I could have corrected her femurs more, I would have. I was bending the Chance pins with the Distractor. So take homes from that one are address the bone metabolism, because you want to be successful with these big surgeries, and getting their bone ready for people who have metabolic problems is really important. Do a thorough evaluation like you've heard throughout the course. And for this one, with femurs and tibias, I didn't want to do all 4 at the same time. That's too much for me and her. So we did staged corrections, and then that got brought up. How much is too much? That's I don't think I'll know until it happens to me, but I gave my things that make me nervous anyway. And then be patient in healing, especially in patients with metabolic bone disorders. So we can kind of go through this a little bit faster if we're starting to run out of time. But this is a 28-year-old who jumped off of his deck because a rabid raccoon was chasing him, and he landed in the dirt and sustained this open type 3B 43C2 tibia fracture that was originally debrided and externally fixated and provisionally plated. The tibia and the fibula is fixed by one of my partners on call. He's an IT specialist, married, has a baby on the way, and does not use nicotine. This is pretty simple articular involvement that you see here. And so I ended up, because my partner was going out of town, I ended up being the one to do his definitive surgery. So this is how he looks on 3 weeks from his injury at the day of definitive intended surgery. So he's got stuff draining out of his wound. He's got a soft tissue defect right here. So definitely not getting the definitive ORIF. So he goes on to, I debrided his bone back to what I thought to be healthy bone, put in a less than adequate antibiotic spacer at that point. This is what I would do now. This was 10 years ago. And he had cultures that grew out Pseudomonas. So he's got this acutely infected 43C2 pilon fracture, and he's on ciprofloxacin to address the Pseudomonas. So what do you guys think we should do?
Is there any thought of securing the joint with independent screws, even in infection? At the
Say
very
that again.
beginning?
I'm sorry.
Any indication, or is it legal, not malpractice, to put in independent screws across the joint percutaneous, even if it's infected, to secure the articular lesion?
Yeah, for sure. So he's still in the hospital at this point.
But even on the clinical photo before, like if that wound was pussing out, I may have been enticed to put in even temporary wires beneath the skin like Benershka would do, or independent screws. Just a thought of.
Yeah, I think that's fine for sure. Definitely, I wouldn't leave it alone for 6 to 8 weeks while you're treating them with IV antibiotics. I would put something across there before. Sorry, did somebody else say something?
Well, I didn't answer your question because you asked the question. I sort of said something else. So the question was now what to do, correct?
Yeah.
Okay. Well, I would make a problem list and see what the issues are. So I would see how much bone loss he has, maybe 6-7 centimeters there.
Yep.
It's infected with Pseudomonas. He's IT, so he likes cool gadgets. So I would talk to him about a X-Fix to wear for 12 months. He'll probably like that. And I would get a plastic surgeon, and I would probably treat this with a circular fixator and a transport. All X-Fix transport, no internal fixation.
Tim or Sean?
I'm going nail transport over nail ultimately. So for infection eradication, I would lean more towards beads, just for the increased surface area, more acutely, and then ultimately transition that to, if he's got medullary involvement, antibiotic rod with antibiotic safe spacer with free flap coverage. And then I would do a simple 3-ring on rail transport over a nail. It's right kind of at my edge for where I'd be interested in masculating it. And it's not because some textbook randomly says 6 centimeters. I just eyeball it, and that looks like I would probably plan to do a transport over a nail.
Okay. Sean, in 2020, what beads are you using? Beads from the pharmacy at Harborview, or beads that you make, or beads from a company with a little ice cube tray?
So the FDA busted us. So our incredibly easy off-the-shelf vancomycin and tobramycin perfect beads got removed, and I cannot make a bunch of little rocks. So I do take a company's dissolving calcium sulfate and use tobramycin and vancomycin. It's more expensive, but I think it's a big surface area. And I haven't had a lot of problems with drainage. I know others have.
Yeah, I think the company that you're talking about, you want to use less of the, less antibiotics and less of the monomer, and it gets less drainage. But so what would be your timing of all that, Sean? Like, what would be the sequence? So you're going to debride him and put the antibiotic nail in like within a week? Are you going to?
Yeah, I would get antibiotic beads in there and get this covered and be satisfied that I've eradicated the infection. And then so for 6 weeks, and then I would take external fixator off, antibiotic nail down if I was still nervous, and even stage it to that point to get a rod down, even if it's just 2 weeks of an antibiotic nail. Just because, and this is like the difference. Mitch is like, why are you doing all these extra steps? Just transport. Because I'm the occasional transport guy, and I just can't imagine a docking site miss and all of those issues. So I try to get an intramedullary nail in so that I can transport over the nail, because I never miss with my docking site if I'm transporting over a nail.
Tim, anything different from what's been said? Would you do anything?
Yeah, maybe a couple things. Only because I transport less than Sean. So I do like the idea of getting to a nail. And I absolutely love the bead pouch early on. I think that we've gotten away from, or it feels like we've gotten away from the bead pouch. People are either quick to put a block in there or run a vac on it. And I really like antibiotic beads and IABAN over it and let it just sort of bathe in there until we get it clean. And then as soon as we get it clean, get a nail down. But I'm probably leaning more towards a mascale for me, because that's sort of, I've got more experience doing that. It's cool that we've got 3 different answers to the exact same problem. This area, though, this metaphyseal area of the tibia is usually pretty good with regards to a mascale bone grafting later on. It seems weird that he pussed out so quick with Pseudomonas. I mean,
he pounded the dirt.
Only a week or so?
3 weeks from his ex-fix and debridement.
Yeah, that's pretty quick. But and to Mitch's point, I would try to get something across the joint early.
Okay.
Couple screws.
Yep.
Doesn't need anything super big.
Okay.
Sorry.
Hey Brett.
Yeah.
I just to make it something different. Even I'm trying to get to a nail too, but I don't like the X-Fix on there, so I've been doing a submuscular antibiotic coated plate.
Yeah.
I can get the X-Fix off, put it under a big muscle flap, and then let everything calm down. Yeah, fix the joint, but then that plate can get taken out pretty simply, and then I'm a little less nervous about the acute nail conversion to either, one of Mitch's fancy distraction nails, or even into a transport situation over a nail where I have less concern about canal contamination.
Yeah, I think that's a great point. This happened when we didn't have great soft tissue coverage partners.
Brett, we're all talking about 2-stage, correct? None of us mentioned single stage treatment, correct? Like no one's saying debridement, definitive fixation at the same time.
I don't think so.
That is discussed, right? So that is out there in the literature. No, Sean saying no. Is that a no?
No, I'm not saying that it's not in the literature, but a 3-week-old Pseudomonas infection with a tibia with the previous dirt biopsy, I would be really nervous about doing anything other than beating this for a while.
Okay.
All right. We're getting close on time, so we'll kind of power through here. So 1 week, so he got another 2 debridements, and then he got your fancy screws at the bottom, Mitch. So there you go. Articular surface fixed. And then did transport with a ring. I would say now I'd probably treat the infection for a couple weeks with antibiotic nail and either an X-Fix or a plate, like Mark had said. And I definitely would have gotten a free flap done by now, but this guy didn't end up getting a free flap. But that was part of the decision making. And then he didn't distract a week later. That was over time. And this is the guy that actually made me always tell people to turn it towards one of their shoulders, because he told it the wrong way. And he turned it the wrong way and dislocated his proximal tib-fib joint when I was at the OTA in 2009. So that was an awesome call.
Classic.
But he actually, I went back and looked at his film. So he is in some varus here, and I'll show you the films, but he had some pre-existing varus of his tibia. But like you said, 12 months later, his frame was on for 13 months. And he did get some arthritis in his ankle, but he wouldn't let me do anything else for him. So he was walking around without any assistive device and able to do his IT desk job well, and he would bring his baby in as she would kept growing up, and so it was kind of neat to see that. But this is his MPTA, which is, I mean, it's 77, so it's not great. And his proximal tibial angle is a little exaggerated as well. But the take-homes are manage the infection, address the articular surface, like you said, and I think it's important. I'm much more aggressive fixing that earlier than later, for sure, just because of the problems that come along with delaying the articular fixation. Determine the technique based on the patient and their goals, and then frames can take forever. So the whole module, the take-homes, are list the indications for tibial deformity correction and non-union management, utilize deformity correction for extra-articular alignment as well as intra-articular for the distal tibia, and then recognize lengthening and transport techniques. And so we have one more Saturday. So Saturday is the last live event for now. At least it's the last online one. This is where you go to the splash page at the AONA website, and you can click on that to learn more. We just have one more on June 20th. It's the discussion groups for the diaphysis and the tibia, and we listened to the feedback we got from the participants that you guys wanted it done as an expert panel discussion where the faculty present their cases, and you can ask questions and we'll ask questions and kind of give each other a hard time. And then just remember to sign up for that. So that's Saturday. And then you will be able to get the Zoom recording within 24 hours, and then it will be posted to the AO Trauma North America YouTube channel. All of the previous sessions are on there, so if you haven't been able to watch them, catch up. And it's broken up by individual lectures and modules, so you don't have to watch the total of an hour and a half. You can watch a 10-minute talk here and there. So it's a great resource, and it's free. Then we are planning for the live event, November 13th and 14th at the Aquindo Center in Las Vegas. It's a great venue. Whether you like Vegas or not, it's a great place to learn how to do anatomical dissections, and we're going to do cadaveric osteotomies, do some bone transport, frame placement. We're going to do some synthetic bone. We're going to do the mathematically directed osteotomy. It's going to be a low participant to faculty ratio. It'll be a great event, and it'll be a Friday afternoon, Saturday morning, and then we'll have a Saturday event with faculty where the participants and the faculty will have a dinner and get to know each other better, and hopefully form mentorship relationships, which can be both ways, from you guys to us and us to you guys. And we're still hoping with the pandemic that we'll get it figured out. But we will eventually, even if it doesn't happen in November, we're going to have a live event. Other upcoming AONA events, the pelvis and acetabular course is going to be online starting July 11th, and kind of similar to what we've done, work through August 29th. And these are the co-chairs, Dave Steven, Mark Riley, Steve Sims, all who are great pelvic and acetabular experts. So look out for marketing for that, and join for sure. This is the agenda. So this is the week by week agenda. And so we have a couple of specific questions about the live event. So Angel, if you can show that. So yes or no if you're planning on coming to the live event, because we want to know if we need to do more than one, because in November we're more than likely still going to have a limitation for participant numbers at the live event, and we want to make sure everybody has an opportunity. And then there's also limited space at the Aquindo Center. And then if a lot of folks have tuned in from Latin America, would you be interested if you can obviously come to Las Vegas, but if it's easier to go to Miami, we thought about having one in Miami. And then eventually we're kind of toying around with the idea of maybe one in the Middle East. We've had a lot of Middle Eastern folks tune in as well. So we're trying to come up with live event locations that'll be accessible for everybody. And so at least for now, please indicate whether you'll attend the live event in Las Vegas, or if there's another one in Miami, if you're able to join there. And then after those questions are done, we have our standard evaluation questions. And thank you so much for joining in. We always love to have folks ask questions, and we think osteotomies are pretty awesome. So thank you for kind of joining us for this online course, and hopefully you guys can join on Saturday. And have a great evening.